Hello my dear friends, I hope you are well. Today we want to talk about primary and secondary hypertension. And finally I want to explain to you the nursing diagnoses and necessary actions for each of them. So, without wasting time, let's get to the point. Arterial hypertension definition. Hypertension is defined as a persistent elevation of systolic blood pressure 130 mmHg or higher and/or diastolic blood pressure 80 mmHg or higher, according to the ACC/AHA 2017 guidelines. In many countries, including Iran, a threshold of 140/90 mmHg or higher is still widely used in routine clinical practice. Classification of blood pressure category: SBP/DBP. Normal less than 120, less than 80, elevated 120 to 129, less than 80. Hypertension stage 1, 130 to 139, 80 to 89. Hypertension stage 2, 140 or higher, 90 or higher. Hypertensive crisis 180 or higher, 120 or higher. Types of hypertension. 1. Primary hypertension prevalence accounts for 90 to 95% of cases. Pathophysiology. Increased sympathetic nervous system activity. Overactivation of the renin-angiotensin-aldosterone system. Endothelial dysfunction. Increased peripheral vascular resistance. Salt sensitivity. Polygenic genetic predisposition. Obesity. Insulin resistance. And chronic inflammation. Risk factors: advanced age, positive family history, obesity and metabolic syndrome, high sodium intake, chronic stress, physical inactivity, alcohol consumption, obstructive sleep apnea. 2. Secondary hypertension prevalence, 5 to 10% of cases, up to 20 to 30% in resistant hypertension, major causes, renal causes, chronic kidney disease, glomerulonephritis, renal artery, stenosis, atherosclerotic, fibromuscular dysplasia. Endocrine causes: primary hyperaldosteronism, pheochromocytoma, Cushing's syndrome, hyperthyroidism, hypothyroidism, acromegaly, hyperparathyroidism. Cardiovascular causes: coarctation of the aorta. Respiratory causes: obstructive sleep apnea, drug or toxin-induced. NSAIDs, oral contraceptive pills, glucocorticoids, cyclosporin, tacrolimus, erythropoietin, cocaine and amphetamines. Other causes: pregnancy-related hypertension, increased intracranial pressure. Diagnostic methods for hypertension. 1. Proper office blood pressure measurement. Patient seated, resting for at least 5 minutes. Appropriate cuff size, measurement in both arms, at least 2 to 3 measurements on different days. 2. Ambulatory blood pressure monitoring, gold standard used to diagnose white coat hypertension, elevated BP in clinical settings. Masked hypertension, normal office BP but elevated home BP. Nocturnal hypertension, non-dipping pattern, absence of normal nocturnal BP decline. 3. Home blood pressure monitoring. Diagnostic workup baseline investigations, complete blood count, fasting blood sugar, HbA1c, lipid profile, blood urea nitrogen, creatinine, eGFR, serum sodium and potassium, urinalysis, plus albumin to creatinine ratio, electrocardiography, additional investigations, aldosterone to renin ratio, plasma or urinary metanephrines, thyroid function tests, cortisol, renal Doppler ultrasound, CTA or MRA, polysomnography, echocardiography. Clinical manifestations: hypertension is often asymptomatic. Possible symptoms include morning headaches, dizziness, palpitations, fatigue, blurred vision, epistaxis, dyspnea. Complications of hypertension: cardiovascular, left ventricular hypertrophy, coronary artery disease, heart failure with preserved or reduced EF, atrial fibrillation, sudden cardiac death, neurological, ischemic or hemorrhagic stroke, vascular dementia, ophthalmologic, hypertensive retinopathy, papilledema renal, chronic kidney disease, proteinuria, end-stage renal disease, vascular, aortic aneurysm or dissection, peripheral arterial disease due to atherosclerotic plaque formation. Management of hypertension. 1. Non-pharmacological management, diet, reduced sodium intake, increased intake of potassium, fruits and vegetables, lifestyle modifications, weight reduction, aerobic physical activity at least 150 minutes a week, smoking cessation, alcohol reduction, treatment of OSA. 2. Pharmacological management, ACE inhibitors, enalapril, lisinopril, ramipril, captopril indications, diabetes mellitus, chronic kidney disease, heart failure with reduced ejection fraction, adverse effects, dry cough, angioedema, hyperkalemia, increased serum creatinine, ARBs, losartan, valsartan, candesartan, telmisartan, used as alternatives in patients intolerant to ACE inhibitors. Calcium channel blockers, dihydropyridines, amlodipine, nifedipine, non-DHP, verapamil, diltiazem, adverse effects, peripheral edema, constipation, bradycardia, diuretics thiazide, ubiquitous, indeiporic, thiazide-like, hydrochlorothiazide, chlorthalidone, indapamide, first-line agents in primary hypertension, beta blockers, metoprolol, bisoprolol, carvedilol indications, coronary artery disease, heart failure, cardiac arrhythmias, aldosterone antagonists, spironolactone, eplerenone indicated in resistant hypertension, other antihypertensive agents, alpha blockers, central agents, direct vasodilators. Resistant hypertension, defined as uncontrolled BP despite 3 or more antihypertensive agents, including a diuretic, at optimal doses. Evaluate for poor medication adherence, secondary causes, excess sodium intake, obstructive sleep apnea. Management of secondary hypertension focuses on treating the underlying cause. Renal artery stenosis, revascularization, Conn syndrome, adrenalectomy, bilateral disease, managed with mineralocorticoid receptor antagonists, pheochromocytoma, alpha blockade followed by surgery, OSA, CPAP therapy, hypertensive crisis, hypertensive emergency, evidence of acute target organ damage, requires ICU admission, IV medications, nitroprusside, nicardipine, labetalol, hypertensive urgency, no acute target organ damage, oral medications with gradual BP reduction. Summary: hypertension is a multi-system, chronic, and preventable disease. Accurate diagnosis, differentiation between primary and secondary hypertension, and individualized treatment strategies are fundamental to effective management. A multidisciplinary team approach, including physicians, nurses, laboratory sciences, imaging, and digital health, is essential for optimal patient outcomes. Nursing diagnoses related to primary and secondary hypertension. Multiple nursing diagnoses may coexist. Selection must be based on comprehensive holistic nursing assessment. 1. Ineffective tissue perfusion types: cerebral, cardiac, renal, peripheral, related to chronic elevation of arterial blood pressure, atherosclerosis, left ventricular hypertrophy, vascular narrowing, and increased vascular resistance. Defining characteristics, evidence: headache, dizziness, decreased level of consciousness, chest pain, decreased urine output, cold extremities, nursing interventions and care, accurate and regular blood pressure monitoring, preferably using ambulatory blood pressure monitoring or home blood pressure monitoring when applicable. Neurological assessment, including Glasgow Coma Scale and pupillary examination. Continuous or intermittent ECG monitoring in patients with cardiac involvement. Monitoring of intake and output, urine color and urine volume. Prevention of sudden hypotension or abrupt increases in blood pressure. Immediate reporting of signs and symptoms suggestive of tissue ischemia. Patient education regarding early warning signs and the importance of prompt reporting. 2. Risk for decreased cardiac output related to left ventricular hypertrophy, hypertension-induced heart failure, cardiac arrhythmias, nursing interventions, continuous monitoring of vital signs and heart rate, assessment for signs and symptoms of heart failure, daily weight monitoring, implementation of fluid and sodium restriction as prescribed, monitoring therapeutic effects and adverse reactions of medications, education regarding avoidance of excessive physical exertion. 3. Activity intolerance related to increased cardiac afterload, heart failure, tissue hypoxia, defining characteristics, fatigue, dyspnea, elevation of blood pressure or heart rate during physical activity, nursing interventions, planning and implementation of individualized activity rest schedules, monitoring blood pressure before, during, and after activity, education on gradual and progressive increase in physical activity, application of energy conservation techniques, referral to physiotherapy services when indicated. 4. Risk for target organ damage, target organs, heart, brain, kidneys, eyes nursing interventions, monitoring laboratory values, assessment for visual disturbances and referral to ophthalmology when indicated, patient education on the importance of optimal blood pressure control, ensuring regular follow-up and adherence to pharmacological therapy, accurate documentation and trend analysis of blood pressure readings. 5. Ineffective therapeutic regimen management related to complexity of treatment regimens, knowledge deficits, medication-related adverse effects, socioeconomic and cultural factors, defining characteristics, irregular medication intake, poorly controlled blood pressure, nursing interventions, clear, simple, and patient-centered education regarding prescribed medications, explanation of common side effects and appropriate responses, encouraging use of medication organizers, identification and management of barriers to treatment adherence, involvement of family members in care planning, education on home blood pressure monitoring techniques. 6. Imbalanced nutrition, more than body requirements, related to obesity, excessive sodium intake, nursing interventions, education regarding the DASH diet, instruction on interpreting nutritional labels, reduction of dietary sodium, saturated fats, and refined sugars, monitoring of body mass index and waist circumference, referral to a clinical dietitian. 7. Risk for electrolyte imbalance related to diuretic therapy, ACE inhibitors, ARBs, renal impairment, nursing interventions, regular monitoring of serum sodium and potassium levels, observation for clinical signs of hypo or hyperkalemia, patient education regarding warning symptoms, adjustment of dietary intake based on prescribed medications, prompt reporting of abnormal laboratory findings. 8. Disturbed sleep pattern related to hypertension, obstructive sleep apnea, anxiety, nursing interventions, screening for OSA using validated tools, education on sleep hygiene practices, encouragement and reinforcement of adherence to CPAP therapy, reduction of caffeine intake, optimization of the sleep environment. 9. Anxiety related to diagnosis of a chronic disease, fear of complications, hospitalization, defining characteristics, restlessness, elevated blood pressure, persistent worry, nursing interventions, establishment of a therapeutic nurse-patient relationship, gradual and structured patient education, teaching relaxation and stress reduction techniques, referral to mental health professionals when indicated, encouraging family presence and support. 10. Risk for falls related to orthostatic hypotension, antihypertensive medications, advanced age nursing interventions, measurement of orthostatic blood pressure, education on slow and safe position changes, use of assistive devices as needed, environmental safety modifications, application of fall risk identification measures. 11. Risk for renal perfusion impairment, related to long-standing hypertension, renal causes of secondary hypertension, nursing interventions, accurate monitoring of intake and output, assessment for peripheral and generalized edema, monitoring of serum creatinine and urine characteristics, education on the role of blood pressure control in renal protection, coordination of care with the nephrology team. 12. Acute pain, related to hypertensive crisis, severe headache, aortic dissection, nursing interventions, systematic pain assessment using validated pain scales, monitoring blood pressure during episodes of pain, administration and evaluation of prescribed analgesics and antihypertensive agents, immediate reporting of severe or unrelieved pain. 13. Readiness for enhanced health management identified in clinically stable and informed patients, nursing interventions, patient empowerment and self-management support, active participation of the patient in decision-making, goal-oriented and individualized education, encouragement of self-care behaviors, special considerations for specific clinical settings, intensive care unit, continuous blood pressure monitoring, prevention and early detection of hypertensive emergencies, dialysis units, strict blood pressure monitoring before, during, and after dialysis, adjustment of dry weight, older adults, vigilance for orthostatic hypotension, less aggressive blood pressure targets, palliative care, symptom control prioritized over strict numerical blood pressure targets.